Okay, let's dive into this. Welcome to today's Explainer, where we're going to embark on a really deep dive into one of the most fascinating yet kind of misunderstood marvels of modern medicine, inhalational anesthetics. I mean, think about it. Every single day, thousands of people breathe in these invisible gases and just drift into a profoundly deep state of unconsciousness, completely shielded from the trauma of surgery. But how exactly does that magic happen? And more importantly, how do we control it? Today, we're going to break down the actual science of how these chemical agents work, walking through the historical milestones to truly demystify the art of going under.
So here's our roadmap for the explainer. We'll start with the magic of going under, get into the science of sleep, check out the early anesthetics, explore modern vapor masterpieces, discuss the trouble of nitrous, and finally wrap up with the quest for perfection.
Section 1. The magic of going under.
When we talk about general anesthesia, we're really aiming for amnesia, muscle relaxation, and a total loss of pain responses. But the human body doesn't just switch off like a light bulb. It actually happens in 4 classical stages. Stage 1 is analgesia. The patient feels less pain, but they're still conscious. As the gas concentration ramps up, we hit stage 2, which is disinhibition. And this is actually a pretty chaotic phase. The brain's inhibitory centers are depressed, and that can lead to involuntary movements or even excitement. So the anesthesiologist really wants to push through this phase as fast as possible to reach our golden target, stage 3. That's surgical anesthesia. The patient is perfectly still, completely unaware, and ready for the scalpel. So the whole trick here is safely landing the patient in stage 3 without ever letting them slip into stage 4. Because stage 4 is medullary depression. That's where the brainstem literally stops telling the heart and lungs to work, which is obviously completely life-threatening. So the entire science of anesthesia is essentially the mastery of hovering safely right there in stage 3.
Section 2. The science of sleep.
To maintain that super delicate balance, pharmacologists and doctors needed to define the rules of the game, right? They needed a standard to measure all these chemical agents against. If you were to walk up to an anesthesiologist and ask them to build their absolute dream drug, they'd hand you this exact wish list. The ideal agent would put you to sleep in seconds and wake you up just as fast. It would be cardiostable, meaning it wouldn't tank your blood pressure, and it would actually open up your airways, which is known as bronchodilation. We'd want absolutely no nausea or vomiting when you wake up. It obviously shouldn't be flammable because operating rooms are packed with oxygen and electrical equipment. It needs to be cheap, and crucially, it should undergo zero biotransformation. That basically means the body doesn't metabolize it into any toxic byproducts. You simply exhale exactly what you inhaled. The whole history of anesthesia that we're about to look at is really just a relentless quest to check every single box on this wish list.
Now, to compare these drugs, we have to measure their strength, and that brings us to MAC, or minimal alveolar concentration. Think of MAC as the ultimate measure of a drug's potency. It's the percentage of gas in the lungs required to stop 50% of patients from moving when a surgeon makes an incision. But what's really wild about this is that this number isn't fixed. MAC can decrease, meaning you actually need less of the drug to keep the patient under if the patient is older, hypothermic, or acutely intoxicated with alcohol. On the flip side, if a patient is very young, running a high fever, or has a history of chronic alcohol ingestion, their MAC value increases, and that means the anesthesiologist has to crank up the gas to keep them asleep.
Okay, so the second golden rule is the blood/gas partition coefficient, or B/G. This is what dictates how fast a drug actually works. Now pay close attention to this because it's actually highly counterintuitive. B/G measures how well the gas dissolves into your blood. Now, you'd probably think that a highly soluble gas would get to the brain faster, right? But it's actually the exact opposite. Think of the blood like a massive, empty reservoir. If a gas is highly soluble, the blood aggressively absorbs it and just hoards it. It fills up its reservoir before letting any of the gas travel to the brain. So a high B/G number actually means a very slow induction into sleep.
And this brilliantly illustrates that exact concept. Take halothane, for example. It has a relatively high solubility, with a BFG of 2.5. Because the blood acts like a sponge, just soaking it all up, the patient falls asleep quite slowly. But then look at nitrous oxide. It has a very low solubility of 0.47. The blood barely wants to hold on to it at all, so the gas quickly bypasses the blood reservoir, shoots straight up to the brain, and induces sleep super rapidly.
Let's see how this builds across all the major agents we use. Notice the historical trend here with the BG values. We start with older drugs like ether, which has an absolutely massive BG of 12.0. But as we move toward modern drugs like sevoflurane and desflurane, those numbers just plummet down to 0.69 and 0.42. Over the years, medicine has continually engineered newer agents to be less and less soluble in blood, strictly so doctors can put patients to sleep and wake them up much, much faster.
Section 3.
The early anesthetics.
All right, so these are the historical heavyweights that really paved the way for modern surgery. And we've got to start with diethyl ether. Introduced to the world in Boston back in 1846, this stuff was an absolute revolution. But man, it was far from perfect. It was highly flammable, making the operating room a genuine fire hazard. It was pungent, it irritated the lungs, and it caused terrible nausea and vomiting. Plus, as we just saw, it has that staggering BG of 12, meaning patients took forever to fall asleep and to wake up. Yet, ironically enough, that massive BG value was actually its saving grace. Because it acted so incredibly slowly, it was virtually impossible to accidentally overdose a patient into stage 4 medullary depression. So it was actually incredibly safe, even in the hands of completely inexperienced doctors.
Then, fast forward to 1956, and we get halothane. It solved a lot of ether's problems. It was non-flammable and had a pretty pleasant, sweet smell, which made it fantastic for putting kids to sleep. But halothane had some pretty fatal flaws hidden right beneath that sweet exterior. It caused serious myocardial depression, basically tanking your blood pressure. And even more frightening, it sensitized the heart's conduction system to catecholamines. That means if a surgeon injected adrenaline during an operation, the patient's heart could suddenly break into fatal arrhythmias. And if that wasn't enough, in a small percentage of cases, the liver metabolized halothane into a toxic byproduct that caused severe, sometimes fulminating, hepatic necrosis. They literally called it halothane hepatitis. Because of that, patients couldn't be re-exposed to it within a 3-month window.
Section 4. Modern Vapor Masterpieces.
So, the flaws of halothane drove scientists right back to the lab. And that kicked off the era of synthetic tweaking. Chemists started rearranging fluorine and chlorine atoms to build this whole new cast of characters. N-fluorine came first, but at high concentrations it could cause epileptiform spike activity in the brain, leading to localized muscle twitching. Definitely not something you want, especially for an epileptic patient. Isoflurane followed. Now, it's a wonderful drug that avoids liver toxicity entirely, but it can cause something called coronary steal syndrome, where blood is actually diverted away from narrow, diseased heart vessels. However, it doesn't raise intracranial pressure, which makes it the absolute favorite for neurosurgery. Then there's desflurane. It's incredibly fast, but its extreme vapor pressure means it would literally boil away at room temperature. Hospitals actually have to use a specialized electrically heated Tech-6 vaporizer just to safely contain and deliver the stuff. And finally, we have our modern workhorse, sevoflurane. It's got a pleasant odor, extremely fast induction, causes bronchodilation, and boasts the least respiratory depression of all the modern volatiles. It really comes the closest to our ideal wish list.
Section 5. The trouble with nitrous.
But what about the gas that started it all? Stored in those heavily pressurized blue cylinders, nitrous oxide, or laughing gas, is the only inorganic gas still used in anesthesia today. And let me tell you, it plays by a very unique, kind of sneaky set of rules. Remember our chat about MAC, the measure of potency? Well, nitrous oxide has a staggering MAC of 104%. Since MAC represents the alveolar concentration required, having a MAC over 100% means that even if a patient breathed entirely pure nitrous oxide with absolutely zero oxygen, they still wouldn't be deeply anesthetized enough for major surgery. It is literally impossible to achieve surgical anesthesia using nitrous alone at standard atmospheric pressure. Because of that, it is strictly used as a supplement to other, stronger agents. But here is where nitrous gets genuinely troublesome. Nitrous oxide is 35 times more soluble in the blood than regular air, and because of this extreme solubility difference, the volume of nitrous oxide diffusing into closed body cavities vastly exceeds the volume of air diffusing out. It aggressively invades any air-filled space in the body. If a patient is given nitrous, it can literally inflate their middle ear, their sinuses, or their pleural spaces. So the absolute crucial takeaway here is if a patient comes in with an intestinal obstruction or pneumothorax where a trapped gas pocket could expand and rupture, nitrous oxide is absolutely, categorically banned from that operating room.
Section 6. The Quest for Perfection.
We've seen the fire hazards, the liver toxicities, the muscle twitches, and the inflating intestines. So let's look back at that wish list from the very beginning. Have scientists ever actually found a gas that is lightning fast, perfectly safe on the heart, completely non-toxic, and entirely unmetabolized? Does the perfect anesthetic agent actually exist? Well, the answer, surprisingly, is yes. Meet xenon. It's an elemental noble gas, and its stats are just absolutely mind-blowing. It has a BG of 0.14, making induction and recovery unbelievably rapid. It has a MAC of 70%, so it can safely be given with 30% oxygen. It is extraordinarily stable for the heart, totally non-flammable, doesn't deplete the ozone layer, and undergoes absolutely zero metabolism in the body. It is practically flawless.
But it carries one tragic, monumental flaw. It is astonishingly rare and enormously expensive to extract from the atmosphere. It actually requires highly specialized closed-circuit delivery equipment just to prevent wasting a single drop of it. So for now, it remains a rare luxury of the medical world.
And that perfectly frames the fascinating evolution of this medical miracle. From the chaotic, explosive, vomiting-inducing days of ether in the 1840s through all those chemically tweaked modern vapors, all the way up to the flawless but prohibitively expensive xenon. The ability to safely suspend human consciousness is this incredibly delicate, invisible art that relies on strict laws of physics and biology. As researchers continue to tweak molecules and push to lower those blood gas coefficients even further, it leaves us with one final provocative question. From the explosive volatility of ether to the expensive perfection of xenon, what will the next revolution in the science of sleep actually look like? Thank you so much for diving into this explainer with me.